What is going on, wonderful people? Welcome to The Explainer. I am absolutely pumped today because we're tackling one of my all-time favorite topics, sympathomimetics, also known as adrenergic agonists. We're essentially curing the confused neuron today. We've got the burned-in English subtitles turned on for this explainer, and I highly recommend you read and listen at the exact same time. It really helps make the medicine stick. So settle in, get comfortable, and let's jump right in.
Here's our quick map for today. We'll start with the confused neuron, then meet the receptors, move into the classification of agonists, cover clinical uses and treatments, and wrap up with side effects and contraindications. We're going to break this dense pharmacology down step by step so it makes perfect sense.
Section 1. The confused neuron. Let's just be real for a second, okay? Learning neuropharmacology is notoriously hard. It's like a giant puzzle. You get that dazed expression, right? That classic brain on neuropharmacology look, still trying to figure it out. It drives me absolutely crazy when amateur doctors just throw pills at a patient without actually understanding the underlying drug pathways. They're literally just guessing. But hey, that's not going to be us. By the end of this explainer, your neurons are going to be firing perfectly.
Moving to Section 2. Meet the receptors. So before we even think about prescribing drugs to a patient, we absolutely must understand the battlefield. Let's practice a really great study habit right now. You got to say what you write and write what you say. Sympathomimetics. Sympathomimetic. Mimicking. These are drugs that activate adrenergic receptors, basically mimicking the sympathetic nervous system. They produce that classic fight-or-flight response. Your heart rate shoots up, your airways open wide, and you are ready to either fight a bear or run as fast as you can away from it.
Now let's look at the sharp contrast between the two main teams on this battlefield, alpha receptors versus beta receptors. Stimulation of alpha-1 receptors characteristically produces vasoconstriction. It clamps down the blood vessels, particularly in the skin and abdominal viscera, and that drives up blood pressure. On the flip side, beta-1 receptor stimulation causes cardiac stimulation. That increases both your heart rate and your contractility. Meanwhile, beta-2 receptor stimulation produces vasodilation in the skeletal muscles and bronchodilation. That just means it relaxes the smooth muscles of your lungs so you can breathe easier.
And that brings us to a massive exam-saving pro tip. I want you to say it out loud with me right now. Beta-1 for the one heart, beta-2 for the two lungs. Come on, say it again. Memory hacks like this are the absolute secret to passing exams and actually remembering this stuff in the clinic. One heart, beta-1. Two lungs, beta-2. Boom. Done.
Section 3. Classification of agonists. With our battlefield mapped out, we're going to classify our roster of medications based on exactly how they attack the synapse. Let's walk through this systematically because there are really three ways to get the job done. First up, direct-acting agonists. These drugs, like epinephrine and dopamine, walk right up and kick the receptor door down. They bind directly to the alpha or beta receptors. Second, indirect-acting agonists. Now, instead of kicking the door down, they manipulate the environment. They act indirectly by either blocking the reuptake of norepinephrine or causing its release from the neuron's vesicles. They essentially trap norepinephrine in the synaptic cleft. And third, we have mixed-acting agonists, like ephedrine. These guys do a little bit of both, direct binding and enhancing release.
Let's put a spotlight on those indirect agonists for a quick second. We're talking about drugs like cocaine and amphetamine. Cocaine blocks the reuptake of norepinephrine, while amphetamine triggers a massive release of it. Because of their intense stimulant and pleasure effects, they obviously have a huge illicit market. People tend to think there's some mysterious, magical substance, but biochemically, it's literally just basic adrenergic overdrive. You are just flooding the synapse with norepinephrine. It's simple pharmacology.
Moving to Section 4, Clinical Uses and Treatments.
So when do we actually use these high-alert drugs in the clinic to save a life? Knowing exactly when to deploy them is absolutely crucial. We use these for short-term life-saving treatments: refractory heart failure, cardiogenic shock, hypotension caused by massive hemorrhage or sepsis. Basically, when a patient is crashing, when their blood pressure is completely tanking, we give sympathomimetics to stimulate the heart and induce vasoconstriction just to raise that blood pressure back up. We also use selective drugs like albuterol, which is a beta-2 agonist for asthma to open up those airways, and alpha-2 agonists like clonidine for ADHD.
Here's another massive pro tip for you. Say it with me. Positive inotrope equals increased contractility. When we administer a drug like epinephrine, it hits that beta-1 receptor on the myocardium and it forces the heart to squeeze harder. That positive inotropic action increases the cardiac output, which is exactly what keeps the patient alive.
Section 5, Side Effects and Contraindications.
But listen, everything has a cost, right?
Overloading the sympathetic nervous system comes with some really severe risks. Because these drugs are so incredibly potent, overdose or improper use is a total disaster. We are talking about cardiac arrhythmias in rapid tachycardia. We're looking at central nervous system effects like anxiety, headache, insomnia, and tremors. We are talking about severe hypertension and even pulmonary edema. Look, it drives me up the wall when doctors administer these drugs and just walk away to grab a cup of coffee. You literally cannot just walk away. You are going to give your patient a cerebral hemorrhage. You have to monitor them.
And speaking of monitoring, you need to be aware of a huge danger here. Epinephrine given to a diabetic patient requires extreme caution. Why? Well, because epinephrine actually increases the release of endogenous stores of glucose. It severely spikes blood sugar. So if you have a diabetic patient on an epidrip, their insulin dosage absolutely must be adjusted. If you don't know this pathophysiology, it becomes an absolute nightmare for the patient.
Which naturally brings us to the strict contraindications. Just picture me right now as a stern professor drawing a giant red line right through a patient's chart. Do not use these drugs if the patient has coronary artery disease. Increasing the heart rate and contractility decreases the myocardial oxygen supply-demand ratio, and that precipitates ischemia. Do not use them in patients with hyperthyroidism because they already have an increased production of adrenergic receptors, making their response to epinephrine wildly exaggerated. And finally, be extremely careful in patients receiving digoxin because that combination can easily trigger fatal cardiac arrhythmias.
And that brings us to our final exam question to really test your new knowledge. Let's see what you got. A patient takes an indirect adrenergic agonist that blocks the reuptake of norepinephrine. They present with hypertension and tachycardia. What is the drug? Take a second, think about it, and let me know your answer. I want to see you show off exactly what you just learned. Thank you so much for joining me for this explainer. Stay focused, keep learning, and remember, medicine makes perfect sense once you actually understand what you're talking about.